The
Sorry, you're saying something, Ravi?
the laptop had gone into freeze mode. That is why.
No
Yeah.
issues, no issues.
Thank you.
Okay, we have an interesting case, which as I usually do, all these cases to me are relevant because of clinical decision making. It's not that it is something very unusual or something tricky or something like that. But you will see that if you look at the chronology of the way the patient came to the outpatients and the way the patient was worked up, that's a very standard surgical case. And you take some logical decisions and you come to a conclusion. That's the kind of flow that we had in this case. And so what we will do is have a clinical presentation first from Nikitha up to the point of the end of the history. And then Kritika will tell us about the findings that we had when she came to the outpatients. And there were some things that were done. What should be done? Why was it done? What was done? Why was it done? All that we'll have a discussion on that. And then you guys came and saw the patient. And from then on, you will have the clinical examination findings that Nikitha found when you came to the ward and saw her. And then we'll discuss on the investigations to be done and the course of treatment. That would be the flow for the evening. So please go ahead, Nikitha.
Good evening, everyone. So it is a case of a 48-year-old female who is homemaker and resident of Bangalore. She came with the chief complaints of abdominal distensions since last 2 months, with also complaints of shortness of breath since last 2 months. Patient was apparently all right 2 months back, and she developed abdominal distension, which was insidious on onset, which was progressive, not associated with any pain, no aggravating factors, no relieving factors, relatively reduced after medical attention. Shortness of breath since the last 2 months, which was also insidious on onset, progressive, aggravating on exertion or lying down, unable to walk even shorter distances recently, relatively comfortable in sitting position. Patient also complains of loss of appetite and early satiety, and there is a loss of weight of approximately 4 kgs in the last 2 months. She also complains of generalized weakness and easy fatigability. Complaints of on and off episodes of constipation. Patient is already on syrup laxative. No history of vomiting, hematemesis, loose stools, melena, blood in stools or fever. No history of bladder disturbances or burning micturition. No history of yellowish discoloration of skin or urine or itching. No history of cough or hemoptysis. No history of back pain. No history of headache. No history of swelling or lump over the body. Past history. Patient has a history of abdominal bloating, chest burn and belching for the last 1 year. Was on Ayurvedic medication. Relatively comfortable with occasional medication. History of skin allergy few years back. Was on treatment for the same. Details not available. No medical comorbidities of the patient. No history of previous surgeries. No history of blood transfusions or bleeding disorders. Family history not contributory. Patient has no addictions. Last menstrual period was on 4th of April 2025. Patient has regular menstrual cycles, is nulliparous. No evaluation for infertility or treatment. To summarize the history, a 48-year-old nulliparous female with gastric symptoms of 1 year had developed abdominal distension associated with shortness of breath in the last 2 months, which are progressive. Patient also has early satiety associated with loss of appetite and loss of weight.
All right. So when you talk about gastric symptoms, what do you mean?
Sir, bloating, belching, and chest burn.
Is it related to stomach only?
Esophagus and gastric symptoms.
Only? Would you not get bloating if you have colonic issues? So what is a better term to use there instead of gastric?
Dyspeptic, sir.
Abdominal discomfort.
Abdominal. Abdominal
Abdominal
symptoms for a
discomfort
year. Abdominal
symptoms.
discomfort for a year. Just go back
Okay,
2 or
sir.
3 slides. So, Sai Likith, from what Nikita has told you, what do you think is happening in the abdomen? What systems do you think are involved? At the level of the history, you should have a fair idea of what symptoms, what systems is in what system or systems are involved, and that should direct you to have a focused focused examination of the patient. All right. So, what is the impression that you have now from what Nikita has said?
Abdominal mass.
Okay. So, one of them is a mass. I agree. There is an abdominal distension. It could be a mass. In other words, there's a famous 5 Fs. What is it that occurs to your mind? Causes for abdominal distension.
Fluid.
Yes. Fluid. What are the other Fs? You can't struggle for these things at this stage. Samir.
Flu.
Sir,
Are you outside somewhere?
yes, sir, I'm returning at time.
Returning from where?
I was on leave. I'm returning from the airport. I'm returning.
It doesn't work then. Just disconnect and listen. We can't work with you with that. Yeah. So, Preet.
Feces, latest, and
Yes.
fluid.
Fat.
Fine.
Okay. Those are the things. So, first thing that strikes you is these things. With that, has she taken a complete history or not in terms of the history that she has taken? I just want you to work out in your mind for all these things. What are the things that you would like to know? For fetus, what would you like to know? Last menstrual period. All right. Are you with me? Can you hear me?
Yes,
I
sir.
need answers.
Yes, sir.
Yeah. Has she taken the last menstrual period?
No, sir.
You're not listening to her then. Just go back, show him where. Can you see that? Yeah.
Yes, sir.
You have to be carefully listening to her. Is there any specific history for fluid? What would be the common causes for fluid in the abdomen?
Sir, portal hypertension, cardiac issues, renal issues.
Cardiac disease, renal disease, correct? Is that what strikes a surgeon first? I'm glad you're listening, you're here thinking of those things. But what should strike a surgeon first?
Portal hypertension. Sir.
Yes. Chronic liver disease, maybe. Yes. What else?
Perforated.
Sorry?
Peritonitis.
Peritonitis, she comes with a 2-month history. You don't get peritonitis for 2 months.
Malignancy.
Abdominal malignancy, yes. What else? In India, something that you commonly think of, tuberculosis. So, has she taken enough history regarding all these conditions? Did she ask for questions about liver disease? What were the relevant questions? Let me first say that she's taken a good history, but I want you to know whether you understood the relevance of those things or not. That's right. Yeah. Sorry?
Yellowish discoloration of skin.
Yes, she asked for jaundice. Yes. She asked for history of blood transfusion.
Sir.
Why did she do that?
For tubular hepatitis.
Yes, tubular hepatitis. All right. Did she think about tuberculosis and ask some histories?
So weight loss, loss of
And
cough, chronic cough.
yeah, cough. Yeah. Fever.
Yes, sir.
Okay. She had asked about it. Patient had some breathlessness. Okay. And what about malignancy? What were the things that she asked? If it is malignancy, what malignancy would you be thinking of? Common malignancies in the abdomen that you would be thinking of, that you would want to rule out.
Colon.
Colon. So did she ask about history of colon problems?
No, history.
She did. Bowel
Yes.
history. Yeah. Okay.
And loss
Yeah.
of appetite.
Okay. If it could be pancreas. She talked about loss of appetite, stomach cancer. Yeah. So she did ask about it. There was loss of appetite. There was history. If it's pancreas, you would be thinking of something. What would you be thinking of?
Sir, repeated the
That's
dyspeptic.
one point in history that she did not ask, which concerns pancreas. What would that be?
Rich burping. Sir.
Burping is not pancreatic thing. Back pain.
On and off jaundice.
Back pain.
Okay.
Okay. Did you ask about it, Nikita? I don't think you did.
Sir, back
Oh, you
pain
did.
mentioned.
Actually,
Yes,
you
sir.
have mentioned it. I
We were
missed it.
speaking about the bone and everything, and back
Yes, yes.
pain was concerned,
I
not
was
in your
coming-
pancreas.
Yeah, you must, back, if you have malignant ascites, you can have malignancy elsewhere. So you talk about, maybe secondaries in the spine. You must also think about pancreas as a possibility, and that's what you would like to do. And headache, why would she ask about headache?
Sir, metastasis to.
Yeah, into the brain, and about lump over the body, history of swelling of lump over the body. Same thing, metastatic deposits elsewhere. Okay, so those are the things. So in my view, I think it's a fairly good history that she has taken. So we still don't know, we haven't examined her, and we still don't know what the distension is due to. But as far as the history is concerned, I think it's fairly comprehensive. Ravi, you have anything to add at this stage?
I think it was a very comprehensive and well presented history.
Yeah. Niranjan?
Sir, nothing, sir.
Nothing to add. Okay. So can I now request, in fact, Kritika, you have anything to add? The registrars, you must come in at this stage. Should she have asked for anything else?
No, sir.
No.
Everything is
You think it's good? Yeah. Okay. You
covered
agree?
most of it.
Yeah. Okay. So Kritika, can you give us the findings, please, when we saw her in the outpatients?
Yes, sir. When she presented in outpatients on general examination, she had alopecia. And apart from that, on per abdomen examination, she presented with gross ascites and shortness of breath. On
Right.
examination, initially, that was the only finding.
Chest findings,
And-
Kritika.
Chest findings, there was absent breath sounds on the left side. There
Left
was
side. Correct.
clinically moderate to gross pleural effusion
Yeah.
with gross
You
ascites.
gave the answer. I was going to ask our youngsters what it meant, but anyway, yeah. So there was absent breath sounds and dullness in the left side of the chest. All right, that was the clinical finding. So,
Yes.
yeah. Ines, yeah, go on. Sorry, you want to say add anything more?
No, sir. That's it. That's it.
Any anasarca features of ankle
Um,
swelling or generalized body swelling?
No, sir. No,
No.
anasarca.
No. So, Ines, why would that be important? Anasarca, why would that be important?
So in case of any renal disorder, sir, the present or even in case of cardiac failure,
Correct. So
patient
if it
will
is,
have-
if it is a cardiac or renal disease, you would expect her to have anasarca. And this so-called dullness in the chest and the gross ascites can be a part of that. But because those things weren't there, you would think of more localized problem. All right. So
Yes.
once you clinically think of ascites and left-sided hydrothorax, clinically, you're not sure of it yet. We're going to investigate and then confirm that. But at this point in time, okay, what would be your thoughts? What would be your differential diagnosis? What are the things that you think could have happened to cause this gross ascites and the gross, not the gross, very definite left-sided pleural effusion?
Praveen, what is the diagnosis, man? I think it is staring at your face, at least, as far as initial thoughts are concerned.
Malignancy.
All right. Where would you think
What
of malignancy?
malignancy?
So, abdominal malignancy, like it could be of the
Name
colon,
the common ones. Yeah, colon.
colon,
Mhm.
then pancreatic
Okay.
malignancy as well,
Mhm.
gastric,
Okay. Stomach.
Yes.
Okay.
and so splenic, any splenic involvement,
Very unusual.
Think of the woman,
ovarian,
Yes. So the
ovarian,
common thing that you think of for
Means
stomach,
in-
pancreas, colon, ovary. Okay. Common ones.
Yes.
So always think of the common ones. So those are the things that you have in mind. Why would you expect a pleural effusion? See,
like
you stopped at malignancy. Why not in something else?
so lungs could be one cause of the malignancy, sir, which is causing malignant pleural effusion.
All right. Apart from malignancy, what else can you have with a similar picture? You can't be fixated on things, you must have a very open mind when you clinically look at these people. Otherwise, you'll miss the diagnosis.
Any
Remember-
benign condition?
Yeah,
Benign.
any benign condition giving you this picture.
TB, sir,
Yeah,
tuberculosis.
tuberculosis. Okay, tuberculosis is the next possible diagnosis that you have in mind. Okay.
Yes, sir.
Okay. So at this stage, what would you do?
So
You stop sharing the screen, Nikitha. I will. So go on. Praveen, what would you do? Investigation, clinical examination. Sorry, I'm sorry. Sorry, Nikitha, I'm sorry. You'll have to go on. Please share your screen again. I forgot we haven't discussed the clinical examination that you did when you came.
Shall I go to the clinical
Go to
examination?
clinical
sir, now?
examination. Yes.
Yes. General examination, the patient was conscious, coherent, and cooperative. She looked frail and prefers lying in the bed in semi-recumbent position. ECOG score of 1. Pallor was present. No icterus, cyanosis, clubbing, chylomicronia, lymphadenopathy, and pedal edema. Female pattern baldness at early stage or hair loss was seen. A patient was afebrile with the pulse rate of 98, blood pressure was normal, respiratory rate and saturations were within normal limits. Systemic examination, cardiovascular system S1, S2 heard, respiratory system bilateral air entry was present. Addressing was noted on the left upper back, probably pleural tapping side. Central nervous system, NAD, musculoskeletal, no deficits noted. Abdominal examination, patient is examined in a well-lit room with adequate exposure with a female attendant present during examination. Patient is examined in lying down supine position and knee and hip semi-flex position. On inspection, abdomen was distended. Fullness was noted in the upper left quadrant of abdomen. Umbilicus is inverted and displaced towards right side by few centimeters. All quadrants are moving equally with respiration. A drain tube noted in the right lumbar region with clear straw-colored output, probably ascitic tapping. No obvious distension, skin changes, or visible peristalsis or pulsations seen. No dilated prominent veins or scars seen. Hernial orifices appear to be normal. No cough impulse seen.
Okay, one sec.
On
So
palpation,
one sec. When Sanya, when she said there is a tube noted in the lumbar region,
Yes,
where do you think the tube is? The way she is describing it.
Probably in the Morrison's pouch, sir. Or pelvis, sir. Sorry.
Pelvis. Why not the renal angle at the back?
Yes, sir. That also possible, but
Yeah.
Since she's talking about ascitic tapping,
Yeah.
will it be not into the peritoneal cavity, sir?
It would be, but it
Yes,
could
sir.
also be at the back, right? I mean, so
Yes, sir,
the
possibly.
reason, the point I'm making is what would be a less confusing statement to make? To describe the position.
Is noted in anterior aspect of the right lumbar region.
Lumbar segment. Okay, that's one.
Yes.
Or you can say the right mid segment of the abdomen. Because just, people may pick you on that because lumbar also refers to the back, okay? The region of the renal angle in the line.
Right,
So,
paraumbilical.
yeah, just say right paraumbilical region. Okay, that would be a much easier way to do it. Just a simple, technical issue. When you describe, use the right words. That's all I'm trying to say. Okay, so
Sir,
go
can
on.
I say something?
Yeah, of
Here
course.
there is a first on the first line she has mentioned distended abdomen,
Yeah.
and on the last but third line there is no obvious distension skin changes. So that is something contradictory. So I think
Correct.
it's better that she can omit that no
Correct.
obvious
Sorry, ma'am.
distension.
Yeah, correct.
Discoloration.
Yeah, she should take.
Sorry.
I agree. Take
Yes.
away that distension. There is some
Yes.
distension, but not gross distension. Or you can say no gross distension. All right, you can. Yeah, that's right. Okay. All right, go on.
On palpation, there is no local rise of temperature or tenderness mild tenderness noted at the drain tube side. No guarding or rigidity or obvious gross distension fluid thrill felt. A solitary diffuse oval mass of 15 into 12 centimeters noted in the left upper quadrant, extending from left hypochondrium to left mid quadrant and extending into the umbilical region and epigastric region. It was hard in consistency with smooth surface and ill-defined margins. Inferior margin was felt and superiorly fingers could not be insinuated below the costal margin.
Right.
Mass is not moving with respiration. It was the immobile while trying to move between the fingers. Mass is not palatable and lower margin was prominent on leg raising test.
One sec.
No pulsations felt over the mass.
One sec. Don't keep on going on in such a hurry. You talked about ballotability first. What is ballotability? Can you hear me?
Ballotable generally means floating, sir.
Okay.
The word
But
itself means floating
how do you elicit?
So we're standing, the patient is in a lying down position, by standing on while patient is in the lying down position,
Yeah.
the examiner has to stand on the right side of the patient to examine the right-sided mass.
Okay.
Left hand at the renal angle with the right hand above the abdomen in the mid abdominal portion. Like
Why mid
right lumbar
abdominal?
region,
Why
sir.
mid? Why mid? Anywhere on the mass. Okay, right.
Anywhere
and
on
then
the
what do you
mass.
do?
And try to palpate or move the mass between the two palms.
Yeah.
If
So
it
how
is
do you move it?
moving along with the yes.
Do you do it with a jerk or do you do it slowly? You put it up. How do you do it? You spring it from behind. You spring you spring it from behind, and with your hand, which is not pressed onto the mass, mind you, it is kept in the area of the mass. The mass will come and hit you. Okay, that's what suggests that it is floating, as you said. That is ballotability. But there's one important requirement for that which you did not describe. That's why I'm asking so much. You talked about not moving with respiration. You said it's fixed. It's not ballotable. And before that, you should have made one positive comment. Ines, can you say what you should have mentioned before you check for ballotability?
No renal angle tenderness, sir.
No. Nitya, can you add the first requirement for a ballotability? Bimanually palpable. Okay. There's no question of checking for ballotability if it's not bimanually palpable. So the first statement is, apart from all this, you felt the mass from the front. That's how you described all that, respiration, insinuation of the finger and all that. The next thing is you must put your finger on the flank at the back at the renal angle and confirm that the mass is bimanually palpable. And then you check for ballotable. Got that?
Yes, sir.
Agreed?
So it has to be palpated from the behind first.
From behind and front, you put your hand behind, you're feeling
Yes,
the
sir.
mass, you press from the front, you feel from both hands, with both hands. That is bimanually palpable.
Yes.
And then you do not press from the front, you're keeping it away from the mass a little bit, and then you push from below with a little jerk, and then the mass comes and hits you. Okay? That is bellotability. Classical for what are renal masses?
Masses origin is
Correct.
renal.
Renal masses. Okay, that's classical for renal masses. So go on. So no pulsations felt over the mass elsewhere in the abdomen. Knee elbow position you need not do always. I agree. Rest of the abdomen felt soft. No other masses felt. Liver and spleen could not be palpated. Hernial orifices. How do you say it's not the spleen? If you go back to
could
your
not be
picture, it is
palpated separately.
Sorry?
Yes. Could
This
not be
is-
palpated
If you
separately, sir.
show that picture again, if you show this to me, the first thing I would think of is a splenic mass. The first thing I think of is a splenic mass. How can you say spleen is not palpated? Where do you even think it could not be the spleen? Can you see the shape? Left upper quadrant coming
sir,
towards
yes.
the right. So in
Yes,
your
sir.
description, there is only one thing that will suggest it may not be spleen. And you must still have spleen as your differential
Not moving
diagnosis.
with
So I
respiration.
disagree with you when you say spleen is not palpable. At this stage, it could still be spleen. Movement with respiration is one, but a very large spleen. Yeah, I agree. That's one point for it not being the spleen. Even more important, you can't miss it, Nikita. That's an important point you have to mention.
Finger
Praveen?
insinuation, sir.
No, finger insinuation you have mentioned. Praveen? Supreet?
I'm working with it, sir.
Poking.
Splenic.
Splenic notch here.
Yes.
Okay. Even with large spleen enlargements, generally you do feel a splenic notch, which you did not feel here. Okay. So, but still, just because you haven't felt it, you cannot say it cannot be spleen. You should still have in your differentials the possibility of it being a spleen. Okay. Liver not palpable. So you cannot say spleen could not be palpated. You can say, it could still be spleen, even though that's not my first consideration. Hernial orifices, normal. Next one. Go to the next one.
Percussion, dull note felt over the mass, and test for shifting dullness couldn't be done. Auscultation, vowel sounds were present, no bruit over the mass.
Yeah, why could you not do the test for shifting dullness?
Sir, she was uncomfortable. We asked whether we can
You think she couldn't be turned around?
put her in the lateral position. She was, sir, she was not cooperative to.
All right. Okay, that's why it could not be done. But if she had allowed you to do it, tell me how would you do it in this patient?
Sir, first we start percussing vertically from the xiphisternum to the umbilicus, then horizontally, bilaterally to the either sides.
Okay. You fell for the trap.
Place we
You
felt.
fell. No. Again, you keep on just slowly. You say so that you allow me to interrupt you, because you fell for the trap straight away. Okay. First step, you percuss from above down, and then you percuss bilaterally. Would you do it in this patient bilaterally? That was my trick. Not trick, common sense. I never trick students. Would there be any sense in doing it on the left side on this patient? Are you with me?
Left lower region is devoid of mass.
Yeah, but then your dullness may be higher up.
Sir.
Right? So,
could be, sir.
If you're checking for shifting dullness, you should check for it on the right side of this patient, because there's a large mass on the left side. Would you agree with it?
Yes, sir.
No. Anybody who disagrees? Sanya, what do you say?
Right, sir. You cannot test it on the left side.
Mechanically, don't say bilateral. When there is a mass on that side, try to check it on the side when there is no mass. You'll be more accurate. Okay. Okay. If she had allowed it, that's go on.
Nice.
No,
There is an
you're
ascitic tapping vein on the right side.
right.
So there is tenderness over that region also, sir.
Okay.
So should I can I comment that?
No, I
based
agree
on
with
your
you. I agree
cooperation?
with you that shifting dullness
Yes,
could
sir.
not be done. I have no problem. I have no problem at all with that. I agree that you should not put her through the discomfort. But my theoretical question to you was, which you missed, was which side would you do it? All right. So you mechanically mentioned bilateral. Don't do it. Yeah, go on.
Sir, with
Sanya.
the tube there, all the fluid would be
No,
drained. So
please
talking about shifting dullness in the first place is.
Please understand. Please understand. I am saying if she had allowed you to do it, you would still do it. Okay, without
Correct,
giving
sir,
if
but
you
what?
could.
Yes,
How,
sir. True. If she
how do you know how much of fluid was drained?
Yes, sir.
Yeah.
But
So you would
considering
attempt
that.
it. You would attempt
Okay, sir.
it. And if you did not get any dullness on the lateral aspect, then you cannot do the test. You say there isn't enough fluid to do the
To
test.
do the test.
You
Yes,
must get some dullness on the lateral aspect and then turn the patient over and establish resonance in that area, and then demonstrate the after the patient is turned over, demonstrate the shifting of the dullness from the lateral area to nearer the midline area. That is the test. Okay. But you
Yes,
must,
sir.
if she had allowed you to do it and if she had no tenderness, you would do it. That's the point. Just because the tube is there, you cannot presume that she was completely drained. Understand? So that's what you need to do. Ravi, any comments? As he might have Niranjan, any comments?
No, sir, I have
Sorry,
a
Ravi, you're
cough.
there. Yeah, go on.
I have a cough, so I didn't want to keep coughing.
All right.
So
Fair
keep
enough.
muting myself.
Fair
I think in principle, what sir is saying is they're asking how would you test for shifting dullness, especially in this patient, because I think that is the relevant thing. And I think all the points that you covered are right.
See, that's the point. So don't mechanically say bilateral. I'll check. Okay, if it's only fluid and no masses, no questions. But when there is a mass, no point in looking for shifting dullness or whatever in that area, because the mass will confound your findings. Okay, please go on. Yeah. Next one.
Per rectal examination couldn't be done. Per vaginal examination couldn't be done.
There's nothing
Lymph
there. I can
nodes
tell
are not
you.
palpable in the lymph nodes not palpable in the inguinal and the supraclavicular region.
Right. Good. Okay, go on.
To summarize, a 48-year-old nulliparous female with abdominal symptoms for 1 year had developed abdominal distension associated with shortness of breath in the last 2 months, which are progressive, also has early satiety associated with loss of appetite and loss of weight. On examination, she looks frail and pale with a 15 into 12 centimeters hard, non-tender, ill-defined immobile mass per abdomen in the left upper quadrant with ascitic tapping tube over right paraumbilical region.
Right. Okay. You can't stop there. So you got to tell me what you think it is.
Yes. Sir,
Nikitha, you didn't comment on general.
From the findings, probable. Yes.
Sorry, Ravi was saying something.
Pedal edema.
Sir, there is no pedal edema, sir. In general examination, it was mentioned in general examination, sir.
Yeah, she did. Yeah, go on. I agree with you.
No
it was not mentioned, but you need to give me your diagnosis, provisional diagnosis.
So, provisional diagnosis, probably.
You did not. You must mention it. You don't have a slide on your provisional diagnosis. Impression.
Yes.
Okay. Go on. Right. Okay. Go on. This is good. Yeah. You must have something. You've got to commit yourself to something. Yeah. Go on.
Yes. Respiratory distress and abdominal distension secondary to mass per abdomen, probably malignancy. My first provisional diagnosis would be a large tumor from the tail of pancreas or renal cell carcinoma or retroperitoneal sarcoma fibrosis, considering that the mass is immobile. And the next provisional diagnosis would be splenic mass arising from the splenic from the spleen, either a lymphoma or a cyst, or due to left-sided portal hypertension. The next diagnosis would be splenic flexure of colon carcinoma.
Okay.
And then there is a possibility of omental or peritoneal mass, which could either be tuberculosis or a secondary of a malignancy, metastasis of a malignancy. It could be colonic tuberculosis or gastric carcinoma.
Okay. So,
Considering
Kritika, would
Yes, sir.
would examiners accept such a large list of possible diagnoses?
No, sir. I think
No.
to shortlist at least 3 would be ideal.
Yeah. Okay. So if I asked, I agree with that. So if I asked you to cut it down to, as I said, commonest must come first and the least common must come last usually. So if I asked you to cut it down, Nikitha, what would you say? Would you keep the first 3 in this, or would you rearrange the list and tell me what 3 things are the most commonly possible things?
Sir, to justify the immobility, I would consider the first 3 as the probable diagnosis, sir, initially. But considering the most common things, the pancreas and splenic mass and colonic tuberculosis would be the most common first 3 probable diagnoses, sir.
Okay. Anybody else? Praveen, you have any other thoughts?
Colon carcinoma, sir. Splenic
Okay.
flexion, colon carcinoma.
3, your 3 diagnoses in that order, whichever order you want.
Splenic flexure of colon carcinoma. Colonic tuberculosis, tumor of tail of pancreas.
Tail of the pancreas.
Sir, I have one issue with tuberculosis. Will it
Yes.
present with such a large mass, colonic tuberculosis? It will usually present with stricture.
Yeah.
Rather than a mass.
Yeah. I would agree with that. At this stage, to put tuberculosis anywhere in the top of the list would be unusual, would be unacceptable. It must be some kind of a malignancy. The mass was very easily palpable. All right. The first thing. So would you think of any retroperitoneal lesions there? Like renal and tail of the pancreas, retroperitoneal sarcoma? It's so easily palpable.
Sir, one more thing which still now not come up is adrenal mass, adrenal tumor.
Quite right. Adrenal also should be mentioned, but again, it's a retroperitoneal lesion. To think of that, okay.
No, but adrenals don't grow to that size, sir.
This size, 15 centimeters. I mean, anything can grow, I agree, but it's very unusual. See, I'm not saying it cannot be adrenal at this stage, but you should know what is more spine, a big, large, hard mass in the left upper abdomen without a splenic notch. What would you first think of? Ines.
So to me,
Go on, Nitya.
sir, considering the presentation, I would first consider splenic mass, sir.
Okay.
Because
agreed.
given it is location.
All right.
And I would keep then omental mass. And I wouldn't go with renal cell carcinoma because that has a triad of hematuria should be there. That is not there.
Correct.
And large tumor from tail of the pancreas wouldn't be this palpable. So I would rule out that also.
I agree with that. Any retroperitoneal, adrenal, pancreas, retroperitoneal sarcoma, okay, tail of the pancreas, all this kind of a very easily palpable large mass is unusual, very unusual. So, okay, splenic mass, I would agree. Omental mass, I would agree. Yeah, go on.
Or a splenic flexure ka tumor.
Colonic,
not
large,
colonic.
Large colonic splenic flexure mass, possible. I agree with these things. All right.
But,
go on, Ravi.
But you can't make, I think you shouldn't get this respiratory distress, abdominal distress. I don't think you need to mention that at all.
Yeah.
My differential diagnosis would be mass per abdomen, possible malignancy, and the 3 organs of origin.
So, in fact, So,
the splenic flexure of the colon carcinoma, will it grow into this big size without causing any obstruction, sir?
It can. And it can do that. Really, it can. So, I would change I'm not contesting this list, but I'm contesting the order of the list. Okay, Nikitha? So, I would go for spleen, splenic flexure of the colon and omental mass. And in all this discussion, when you have an omental mass, okay, with such gross ascites and hydrothorax, okay, what you have not mentioned the organ that you would consider as the most common possible thing. We mentioned it in the history itself.
Primary would be at the ovaries or
Yes, you must have that in mind. Okay, so a very, very fundamental question that I'm putting now, I could have put it earlier, Sai Likith. So there was a discrepancy between what Kritika told you when she came to the outpatients and what Nikitha saw a day later. What had happened then? You have the answer, but I want you to understand what you should do in these situations to get a better clinical picture. What has happened? What was done to the patient, which uncovered something?
Ascitic tapping.
Okay, correct. Okay, ascitic tapping was done. What else was done? She also mentioned pleural tapping was done.
Okay.
Is it justified in doing a pleural tap? Why would you want to do a pleural tap?
To know any malignancies.
One is
Infiltration of
diagnosis.
the.
One is diagnosis. I agree. Okay. What else was responsible for our decision to do a pleural tap?
To reduce respiratory distress symptoms.
Yes, correct. She had breathlessness, and so we are completely justified in doing it. So if you're expecting a malignancy, what would you suspect the nature of the tap to be? No trick questions, simple questions.
Malignant cells.
Just tapping, you're not looking at cells. You put a needle in and pull the fluid out. What would that fluid be if it's malignant? If it's a malignant ascites, if it's a malignant effusion.
Hemorrhagic.
Hemorrhagic, that's all. No trick question. Very simple question. Okay. So, Kritika, can you go on?
Can I'm just considering, should we have examined the breast as a part of, because we are keeping malignancy as a this thing, and ovarian is also there, and she's a nulliparous woman. So
You're absolutely right. Did we or
breast
did we
and
not?
spine should have been.
Spine was examined. I think your examination of the back she mentioned.
Yeah.
She examined, but breast she didn't mention. I agree. Did we or did we not examine the breast, Kritika?
Sir, I had examined her later in the ward, sir.
Yes. So we had examined the breast. I agree. And you should have mentioned it, Nikita. I agree with that. I missed it myself. Yeah. You must examine the breast when you're looking at an abdominal malignancy with ascites. Correct. Okay. So you can stop sharing now because I will have to give you the results of all the tests. Okay. I will share. Go on, Ravi.
But Nitya, but to say, no, I fully take your point that the breast had to be examined, but not because she was a nulliparous woman. How will nulliparity, in fact, nulliparity will not actually affect the breast cancer anyway.
But did she mention nulliparity? I think she was
Nitya,
talking
Nitya
about breast cancer. Yeah.
Yeah, Nitya.
And breast cancer more common in nulliparous. Maybe that's what you meant. Did you?
That is why I wanted to correlate this.
All right. Okay. So anyway, the breasts were examined and they're found to be normal. Yeah. Now, what would you do? Praveen, go on with investigations. What would you do and why would you do it? There are two things I want you to tell me. And I'll give you the answer.
Sir, for the diagnosis,
okay.
We'll start with the blood test,
okay.
CBC.
Yeah. What would CBC tell you in this? What would you be expecting in a CBC in this?
Sir, total count to see the infection levels.
Okay.
And hemoglobin.
Hemoglobin. Okay. All right. My hemoglobin was 13. All of you can see the screen, I presume. Okay. So nothing very remarkable. Slight changes. Total count was a little high. Okay. What would you do next?
Sir, LFT, sir.
LFT.
To rule the
Yeah, we did the glucose, creatinine normal, liver function tests. Okay. What are your comments on this?
Highly elevated alkaline
Very
phosphates
slight. Yeah. Nothing really remarkable. Okay, good. Now what else would you do?
Renal
We are
function
looking
test,
at
serum
chronic liver
creatinine
disease, but that chronic liver disease that we started with during history has gone out of the window now because we have a large mass. But anyway, you would look at the LFTs even for a malignancy. If you have liver mets, for example, you can have disturbance in enzymes, but more so in alkaline phosphatase. Yeah. Go on next.
renal function test.
Renal function,
creatinine
I already
levels.
shown, no? Creatinine was normal. This I had done. Creatinine is normal. Yeah. If it's a little bit on the lower side, okay, 0.5 also is normal, but if it's on the lower side, what does it tell you? In a normal functioning kidney, what does the lower creatinine tell you? Which is of some significance to surgeons. Go on, quickly. Nikita.
No idea, sir, actually.
Nitya.
Sir, muscle mass is low.
Muscle.
Excellent. Samir, that's correct. Muscle mass is low. It's of importance to surgeons, okay? Unless you have good protein mass, your wounds may not heal, your infection rates will be higher. So that's something you should watch, not just renal function. It also is a reflection of the muscle mass. Okay. LFT we did. Next, what would you do?
To rule out malignancies,
Yes.
markers.
Markers.
CA99,
Yeah.
CA.
Yeah. We did thyroid TSH also. Okay. Urine analysis. You're talking about renal mass, urine analysis. No blood. Okay. Urine for RBC, absent, no pus cells, nothing. Okay. Occult blood, we looked at, talking about colonic masses. Occult blood was negative. So you understand how all these tests are logically done. That's something you have to understand. Occult blood was negative. Okay. And we did the markers. I will give you the findings later. Maybe I can give it to you now. Okay. What markers would you do? I gave you the answer quickly.
CA and CA99.
99. Is that all you would do?
CA 125.
125.
Thank you. Okay. Those were the three things that we did. Just watch what the CA 125 was. Okay. 99, pancreas, not high. CEA, pancreas, colon, not high. And stomach, even that is there. So that was it. So markers we did a little later, but of course, after we tapped the abdomen, we got, not after we tapped actually, before we tapped, we got the chest X-ray done on clinical grounds. You can see the effusion in that area. Based on that, it was tapped and we did an ultrasound. Okay. This is the ultrasound finding. And this is the impression shown. Hepatomegaly with mild surface irregularity. What would that mean, Ines?
So it could be a cirrhotic change.
Yeah, it could be. It might mean, but it's non-specific, but it might mean CLD. Okay. Enlarged uterus with multiple fibroids, right ovarian cyst, moderate to gross ascites, and left-sided pleural effusion. This was what was mentioned. So what is glaring in the absence here?
The
Nikita.
mass per se is
Mass.
not.
The huge mass, which was not mentioned at all. Okay. And this is the reality in life. It's actually a good ultrasonologist. But sometimes these things happen. Okay. They clearly mentioned left ovary, not well visualized, small cyst in the right ovary. Okay. Theoretically, would ascites block the view of ultrasonologists? Samir, if you're in a quiet place, would ascites theoretically block the view?
Not necessarily, sir.
Would it improve the view? What blocks the view for an ultrasonologist? Gas. Okay. What improves the view for an ultrasonologist?
Fluid, sir.
Sorry?
Fluid.
Clear fluid. Clear fluid.
Yes.
Not turbid fluid. Okay. So a clear fluid actually improves. That's why people make you drink water before you examine the pelvic organs. But if the fluid is turbid, then it can obscure the organs underneath. Okay, so that's probably what happened here, because it was a good ultrasonologist. All right, Nikitha, you please read these. My apologies because I didn't cover the patient's name. I should have done that. So please let me actually do it now. If you don't mind, I'll do it. Because this is, just give me 2 minutes, guys. I'm very sorry I had to do this. Okay. I should have done it first. I somehow missed it. Just bear with me for half a second, because this is going to, yeah. To me, it is an important issue. That's why I'm doing it. Okay. Yeah. Okay. We come to our, yeah. So you can see it now. Yeah.
Yes.
Please read this X-ray for me.
It's sagittal section of the abdomen of a CECT.
Okay.
At the level of
what kind of
mid-level
contrast has
probably
been given?
Sir, IV and oral contrast.
Correct. Okay.
At the level of
Ines,
kidneys.
why does she say that? She's given both IV and oral contrast.
So the aorta is like whitish, so like
Good.
it is,
So IV contrast is given. Yes.
Yes, sir.
Then
so in addition, like the
bowel
bowel
loops are
loops
seen,
are
so oral
also,
contrast is given.
yes, sir.
Right. Simple. All right. Go on. At the level of the kidney, this is the pancreas here. Okay. Clothed over the aorta. What do you see? Is there anything?
No, sir, looks normal.
Looks normal. There is, at the level of the kidney, there is something, you felt a mass there. So what do you think was felt? Is there something in the CT that denotes something which is unusual? Do you have something
At the
in the
abdominal
left,
wall,
in
sir?
the left side? In the left side, that is not there here. You see where my pointer is. That's quite normal, right? Okay.
Yes,
A
sir.
mirror image of this area of the abdominal wall. Do you see anything?
Muscles, sir, which we are not seeing on the other side.
Muscles are seen here nicely.
Yes, sir.
Muscles are, I'm tracing the muscles, you see, these layers.
Yes, sir.
But what is this? Can you see the tip of my pointer? Can you see my pointer?
Yes, sir.
Yeah. What do you see
Yes,
there?
sir.
Serous deposit.
It's a mass.
Diffuse,
That is
yes,
the
diffuse
mass.
mass.
Okay.
Serous deposits.
Yeah. And look at this now. Okay. You can look at this now. What does this show? We have come further down. You can see that
Yes,
we now have the iliac bones here. What is this? What I'm showing here? Can you see that?
Yeah.
Yeah, it's a big mass there. And do you see something which is down here?
Yes, sir.
Yeah, what do you think it is?
Mass
It
arising from
is,
the pelvis.
yeah, it is actually an ovarian mass with a big, what would be abutting the abdomen with such a big cake-like mass?
Omentum.
Mental cake.
All right, it's a big, what you felt was a big omental cake. And on a CT, you even see an ovarian mass. All right, that explains the very high
CA 125.
125. So what would you do next?
Sir, I think when we were discussing the clinical impressions, the fact that patient presented with ascites, the mass, and pleural effusion, the first diagnosis had to be ovarian malignancy because that is the commonest.
Yeah, I agree. But for the sake of discussion, I said we must have a differential diagnosis, but I agree. That's what when I and Kritika discussed it in the outpatients itself, our top of the list was ovarian mass. Okay.
Sir, I'm sure you have done that. The reason I'm saying this is for the students.
Yeah.
There are so many instances where people have, as you said rightly, tuberculosis should be lower down in the, list, because many people label this as tuberculosis, go on treating tuberculosis without, this is diagnosis staring in your face.
Right.
And you will miss the boat. Please do not, if tuberculosis also has to be proved.
Yeah. Very, very right. So, okay, actually, Ravi has given you partially the answer for the question I asked. My latest question. What should we do next? Nikitha, quickly.
Sir, I know what you did, sir.
You're not supposed to answer. You're right. Sorry, I forgot that you were there. Yeah. Okay, Praveen, you're right. Thank you for telling me. Praveen, what should I do next?
To know the diagnosis, to do biopsy, sir.
Yeah,
CT guided biopsy.
CT guided biopsy. What are your options? Okay, CT guided biopsy is one. What else would you do?
Or diagnostic laparoscopy and biopsies.
Correct. Between the two, which would you prefer?
CT guided, sir.
Yeah. What would be the advantages of CT guided biopsy?
Sir, there is one more option, no?
Yeah, go on.
There is one more option of ascitic fluid tapping and cell block.
Quite right. Yeah. So that was done and it was negative. Yeah, I forgot to mention that. Ascitic fluid and pleural fluid were both sent. It was hemorrhagic, but it was negative for malignant cells, but they were exudates. So, Samir, how do I know it is an exudate and not a transudate? Quickly, we are overshooting the time. I will be going about 10 minutes more than 1 hour. Yeah, go on. Samir, are you there? Proteins. How much should be before you differentiate between the two? Hello? What is the cutoff? 3 grams, okay? 3 grams per 100 ml, 30 per liter. I agree. So this was an exudate, but it was negative for malignant cells, and because it was hemorrhagic, we saw some white blood cells, but it was negative for malignant cells. So we're talking about CT guided biopsy. What are its advantages and disadvantages? You must have quick answers for all this. It's all there, It's nothing, no rocket science. It is minimally invasive, right? Less invasive than a laparoscopy. You don't need anesthesia, you just stick it in. But what are its disadvantages? Quickly. You may not, you may do an FNA-C and not necessarily an FNA-B, which means you can only analyze the cells. You may not be able to get the IHC markers and things like that you want to do. So you may be less accurate. So you want to have a good piece of, and of course, it's a blind procedure, even if it's done under CT guidance or whatever, you may hit the bubble. So you want to have something which is more safe and more comprehensive and gives you the answer more clearly. Okay. So between the two, we chose a diagnostic laparoscopy. Okay. This CT, okay, we had discussed all this, so I'm not going to go through this, but this is the report of the CT. Okay. Circumferential wall thickening involving the pyloric canal, which actually misled us. We had done an endoscopy. Remember, I didn't mention it to you. We had done an endoscopy and that was essentially normal, but the CT talked about a circumferential thickening, which we later interpreted as an edema because of the generalized malignancy hepatomegaly with fatty infiltration, all right, nodularity of the omentum with soft tissue lesions, which we saw, enlarged antibiotic, enlarged ovary showing mixed density. So they did describe the tumor, okay, because they thought there was something in the stomach on CT, they called it a Krukenberg tumor. But in actual fact, the stomach was normal and it was a primary ovarian neoplasm. Enlarged lymph nodes along the common iliac and internal iliac vessels. Hydropneumothorax. How did it become a hydropneumothorax? Sai Likith, is he there? It was a hydrothorax, and how did it become a hydropneumothorax? Quickly.
Bronchopulmonary
Bronchopleural fistula.
fistula.
Kritika does a decent pleural tap. She doesn't poke huge things into the lung. Okay, just pleural tap. Okay, when you do a pleural tap, however careful you are, you introduce a little bit of air into it, and that's why it becomes a becomes a hydropneumothorax. Okay, so it can't be a bronchopleural fistula as you thought. Yeah. Anyway, it's just the process of pleural tap. Okay, that was the CT findings that was there. We looked at this. And
Sir,
go on.
Should we not hold the radiologist responsible for such a wrong report?
Good question. I'll not get into it, but honestly, this is a lesson for all of us clinicians. No disrespect to radiologists. Both the ultrasonologist and the CT person actually gave us a misleading direction. But you must have firm convictions in your own thinking, and you must do the needful to get the answer. Okay, so we did the diagnostic laparoscopy and not a CT guided biopsy, because I also feel that our radiologists are not very comfortable doing a CT guided biopsy. Okay, that's one thing. So this is your diagnostic.
Kiran would do, sir.
Kiran would do. Okay, all right. So this is my diagnostic laparoscopy. Okay, we carefully put the scope and look at this huge mass and look at the degree of peritoneal nodules. And this is the area of the colon. This is the under the omentum, and up here is the area of the colon, which is stuck to the ovarian mass. Okay. Yeah. This is the omental mass. So if
you took the omental biopsy, sir?
No. That was the question. Where would you take the biopsy is the next question.
I think there are serosal deposits on the thing and omentum.
Exactly. Yeah, let the students answer, Ravi. Yeah, you're right. Absolutely right. See, the omentum was so grossly caked that I wouldn't get an easy biopsy. Okay, Nishan did it actually. So you'll find that it's much easier to get a huge number of serosal peritoneal deposits. So it was easy for us to just take two large bits of tissue from the serosal, from the peritoneal, parietal peritoneal deposits. That's the correct word. Yeah. See, that's a deposit there. The only thing you should bear in mind is that you should not crush the tissue. Okay, you may even argue that cauterizing it itself can alter the thing, but there was enough of normal tissue there, and so we did.
I think that I was just about to say he is doing such a good job. He's gone to the normal tissue.
Normal tissue outside, correct, and well away from the tumor deposit. Okay, and so. Okay, I'll stop it here. We took one more piece, and that gave us the answer. For lack of time, I will stop it there. Yeah, and so this is the histology. All right. basically said peritoneal biopsy, features of a poorly differentiated adenocarcinoma. At this point in time, they cannot tell you whether it is ovary or not, or what the source is. Okay, even though we know from the CT and all that it's likely to be ovary. What should we do next? Know what the source is. Nikita.
The answer is in the next slide.
It is in the next slide, but you have to tell me,
PA
Nikita.
125.
It's already done,
It's
ma.
already done.
IHC.
It's 3,000.
You see the bottom of this slide.
It's there. The answer is there.
Answer is there on the slide.
Okay. You must do an IHC to get a morphological characterization of the tumor. Okay. And IHC, I thought I had it somewhere, but I think I missed it. Yeah, I have not put it here. But that confirmed ovarian cancer. Okay. It showed the kind of markers which are suggestive of an ovarian cancer. Okay. This is, I hope the discussion was useful to you because this is the way we do it. I don't want to go into the treatment in great detail, but tell me, what would you stage this ovarian cancer as, Nikita? Just 2 lines and then we will close. And I'll put in the group the current thought process in treatment of ovarian cancer. Yeah, you can read it. The big document.
So is there no role of PET scan, sir?
Yeah, I was going to ask you. Yeah, okay.
Since it is
okay, what would PET scan tell you that we already don't know? It's a very good question. We have to. That's why I was going to ask you. How would
any
you?
other distant metastasis?
Yeah, that's why before that, I was going to that, but my question was, what do you think the stage of this cancer is? So you must know the staging of ovarian cancer. Nikita. Okay, if you have not read it, I'll quickly make it. It's stage 4 because I think the pleural effusion, even though it didn't show malignant cells, is malignant. Okay, at least stage 3 because we know that you have lymph beyond the pelvis. It is extending beyond the pelvis, and we know that the lymph nodes are positive and there is peritoneal cavity involvement.
Sir, what was the liver looking like, sir?
Liver looked okay.
So there was no deposits in the liver?
No obvious deposits on the liver. Okay, stage 2, stage 1 is only when it is one ovary or one fallopian tube, 1A, one or both ovaries and fallopian tubes, but not outside the ovary and the fallopian tube. That is stage 1, where you go straight away for surgery. Stage 2, uterus, ovaries, or fallopian tubes are involved, but no extension beyond the pelvis. It can go to other pelvic organs, but cannot be beyond the pelvis. All right. So there you can either go for surgery followed by chemotherapy or consider neoadjuvant. But in stage 3 and 4, when it's got beyond the pelvis, what would you do? That is where the question of PET CT comes into being. You would do that. I think on clinical grounds, this is definitely advanced cancer. And so if you're concerned about the cost of the PET CT, you're within your rights to start neoadjuvant treatment first and then do a PET CT to know the response. If you have enough money and the patient is agreeable, you can establish the volume of the extra abdominal disease through PET CT first. And most medical oncologists do it, even though it's not a standard recommendation. Take it from me. And then give the neoadjuvant chemotherapy and then go for surgery to debulk the disease. Okay. Now, what is the mainstay of treatment in terms of chemotherapy? Nikita. You've not read chemotherapy. You've not read ovarian cancer treatment. So please read it. I won't, because I've gone 10-10. So please read it. It's all theory, so I don't want to go into it. I think I've done what I wanted to do in terms of a logical approach to the diagnosis. I will send you the document about treatment, but I'll tell you very briefly. Neoadjuvant treatment is based on a cisplatin. Okay.
Taxane, sir.
And taxanes. There are 3 things that can be done: cisplatinum, taxanes, and a monoclonal antibody.
Yeah.
Okay. Bevacizumab, that is the monoclonal antibody that can be given. You treat them with it, see what the response is, and then go in and take out as much of the disease as possible and give adjuvant chemotherapy with the same medication again. And if those medications have not helped as experienced in the new adjuvant phase, there's a second line of drugs that you can use, and the medical oncologists do that. Okay. The other thing as surgeons you must know is if you have clinically disease restricted to the pelvis, you can go ahead with hysterectomy and bilateral salpingo-oophorectomy as your initial treatment. You don't need new adjuvant treatment, but that is not the end of the story. Something else has to be done. And what is that, Nitya?
I'm not sure, sir.
Not sure. Sanya?
Pelvic lymph node dissection, sir.
Not necessarily.
Omentectomy, sir.
Correct. You're getting there. What else? Yeah, you're right. What else? So when you're clinically seeing that it's only in the pelvis, you have to make sure that there is no extra pelvic disease. So omentectomy is one part. What else do you do?
HIPEC, sir.
HIPEC not for stage 1. Yeah. HIPEC is for this advanced disease. You're right. That can be done. Yeah. But I'm now asking about clinically early disease. Kritika, you want to answer?
I'm not sure, sir.
Yeah, you must do peritoneal biopsies apart from omentectomy. And where are these biopsies taken? It is the subdiaphragmatic area, from the undersurface of the right lobe of the diaphragm. You must take it from the two paracolic gutters and do an omentectomy. That is a minimum operation that you do when you are dealing with cancer ovary. Okay. And so HIPEC, you're right. It's one of the things that is done apart from the cisplatinum, the taxanes, and the monoclonal antibodies. You can also give HIPEC to control the peritoneal disease.
HIPEC,
yeah.
HIPEC, I know, as far as there are a lot of papers coming out, but still I think HIPEC is efficacy as far as ovarian malignancies, colorectal malignancies are very tenuous. Still not very good.
Yeah, that's true. That's true. And of course, when you're clearing the momentum with malignancy, there are big proponents for peritonectomy. You know, that's a separate topic by itself, and have that in mind, and we will discuss it on another day. Okay. Any questions from the students first?
What did she go ahead with, sir, right now?
Nothing else. We're going
Palliation?
we are going to see some of these people respond very well to chemotherapy, okay, and have prolonged survival. So we're not looking at palliation. We are referring her to the medical oncologist to start neoadjuvant treatment. And hopefully if she responds, we'll then take her up maybe a few months later for, you know, peritoneal clearance, and then give some chemotherapy. And they may have a few years of good existence. She's only 48 years old. So she's definitely not a patient for only palliation unless she doesn't respond to chemotherapy at all. If that happens, then her prognosis is very poor. All right. Any questions? Students first, registrars next. No questions. Niranjan, your comments and followed
Just,
by
one small doubt, sir. So
Yeah,
can
yeah.
we justify in doing a CCT or CT abdomen first by skipping ultrasound if the patient was stable?
No. I think you should have an ultrasound because it's a very easily available, cheap investigation, and this was not helpful, but many times, a large majority of the times, it will be helpful. So you must start with an ultrasound. Yeah.
Sir, good case, sir, and well managed.
Yeah. Ravi, your closing remarks.
Sir, I think I have worked in the largest cancer center in Manchester in Europe, Christie's, and we saw a lot of patients with ovarian malignancies with excellent response to chemotherapy.
Yeah.
And some of them, it works on a hub and spoke model. And the cases I have actually operated for intestinal obstruction with severe, we had to give him a colostomy. And when they reversed the colostomy, the abdomen was clean as a vessel. Absolutely no disease. So, Nikita, don't think it is palliation. I think many of them respond extremely well to the taxane and cisplatin, and then I think you have to debulk the tumor.
Nikita, if you saw a similar disease with pancreas or stomach, for example, or even colon, I would agree with you, it's palliation. But ovary is an exception.
Okay.
Yeah. All right. Okay. Thank you very much. I'll close the meeting
Good
here.
case, sir. Good
Yeah.
case.
Thank you.
sir.
There's another very
Thank you,
nice
sir.
case, which you guys saw the case today. Did somebody see the case yesterday?
No, so today it got very late till we finished OTs.
How sad. How sad.
We'll see tomorrow morning, sir.
No,
before
you will see it in the lab in Sagar. Case operated
No,
on.
so before you take it up for OT, we'll
It's
see
already
it.
taken. It's all done. Already finished today.
So, but the gastric lesion excision was for tomorrow, no, sir?
No,
If I say
it was for today. It was done. Finished. There is another one tomorrow.
yes,
There is
sir,
another one
the
tomorrow, but
excision of gastric
that's
lesion.
not. There's another one tomorrow.
So, but there
that's,
was nothing planned today in your list, if I'm not wrong.
It was.
So nothing.
Yesterday, Kritika told you guys to come and see it yesterday.
Yes, sir. Yes, sir. She told we had.
Yeah. What is
today-
late? Was it 12 midnight?
No, sir.
No.
6:30.
6 o'clock is not late, ma. Life. In a surgeon's life, 6 o'clock is very early.
Yes.
Unless you have that approach, you will miss cases. All right. Okay. Good night.
Yes.
Yeah.
Good night, sir.